Today, an FDA approval in ovarian cancer, a priority review in Hodgkin lymphoma, and highlights from the 2016 ASH annual meeting. Welcome to OncLive News Network. I'm Justin Gallagher. The FDA has expanded the approval of bevacizumab in ovarian cancer to include patients with platinum-sensitive recurrent disease as part of a combination regimen with chemotherapy, followed by continued use of the angiogenesis inhibitor, according to Genentech, which developed the drug. The approval is based on results from two randomized controlled phase 3 studies, GOG-0213 and OCEANS. GOG-0213 demonstrated that adding bevacizumab to chemotherapy led to a non-statistically significant median overall survival difference of 5 months compared with chemotherapy alone. Both studies demonstrated a significant improvement in progression-free survival. In the GOG-0213 study, median PFS improved by 3.4 months with the addition of bevacizumab to chemotherapy compared to chemotherapy alone. The FDA has granted a priority review to a supplemental biologics license application for pembrolizumab for use as a treatment for patients with refractory classical Hodgkin lymphoma. The indication would be for those who have relapsed after more than 3 lines of therapy. The application is based on encouraging results from the Phase 2 KEYNOTE-087 and Phase 1b KEYNOTE-013 trials. Under the priority review, the FDA is scheduled to make a final decision by March 15, 2017. A number of advancements and updated clinical trial results in hematologic malignancies were presented at the 2016 ASH annual meeting in San Diego. CAR T-cell therapies were among the exciting presentations. In results of one Phase 2 study presented, the CAR T-cell therapy CTL-019 demonstrated an 82% complete remission, or CR, with incomplete blood count recovery rate for pediatric and young adult patients with relapsed refractory B-cell acute lymphoblastic leukemia. The study enrolled patients at 25 centers in the United States, Europe, Asia, and Australia. In the first 50 patients enrolled, the CR rate was 68%, and the CRI rate was 14%. Additionally, all patients with a CR or CRI tested negative for minimal residual disease. The 6-month overall survival rate was 89%, and the disease-free survival rate was 60%. Also in ALL, treatment with anti-CD22 CAR T-cell therapy induced an 80% complete remission rate among children and young adults with relapsed refractory B-cell disease, many of whom had prior anti-CD19 CAR T-cell therapy. The high remission rate occurred in patients who received biologically active dose levels of the treatment. It was also found that the remissions were sustained, with 3 patients in ongoing remission now at 3 months, 6 months, and more than 1 year. The CD19-directed CAR T-cell therapy KTE-C19 was found to demonstrate a complete remission rate of 73% for patients with aggressive, chemo-refractory, primary mediastinal B-cell lymphoma and transformed follicular lymphoma, according to findings from another study presented at the meeting. Results showed that the objective response rate with CAR T-cell therapy was 91%, and all CRs occurred within the first month of therapy. After 3 months, both the CR and ORR rates were 64%. Cytokine release syndrome, which is commonly reported adverse event with CAR T-cell therapy, occurred in 91% of patients, but it was primarily low grade. However, there was 1 death related to cardiac arrest in the setting of CRS. By the end of the first quarter of 2017, a biologics license application is expected to be fully submitted for patients with relapsed, refractory, aggressive B-cell non-Hodgkin lymphoma who are ineligible for autologous stem cell transplant. In multiple myeloma, treatment with a combination of pembrolizumab, pomalidomide, and dexamethasone demonstrated promising durable efficacy and a tolerable safety profile for patients with relapsed refractory disease. In a single-center trial, the overall response rate was 65% in the pembrolizumab-containing triplet regimen. Overall, 29% of patients experienced a very good partial remission or better. The stringent complete remission rate was 7%, and the CR rate was 2%. Responses remained consistent in those with double refractory disease and for those with high-risk cytogenetics. In a small phase 2 study, the combination regimen of nivolumab and ibrutinib demonstrated encouraging activity and safety in patients with chronic lymphocytic leukemia and Richter transformation. In the ongoing 13-patient study, the overall response rate was 80% for ibrutinib plus nivolumab in patients with relapsed refractory CLL. In those with RT, the combination elicited a more promising ORR of 60%, which included 2 complete responses. In cutaneous T-cell lymphoma, therapy with brentuximab vedotin induced responses that lasted at least 4 months in 56% of patients. This is compared with the 13% in patients who received physician's choice of standard therapies. At a median follow-up of 17.5 months, the median progression-free survival was 16.7 months with brentuximab vedotin versus 3.5 months with physician's choice. Additionally, the overall response rate was 67% versus 20%, with CR rates of 16% versus 2% in the brentuximab vedotin and control arms, respectively. The addition of venetoclax to bortezomib and dexamethasone showed promising efficacy and acceptable safety for patients with relapsed refractory multiple myeloma, according to the results of a phase 1b study. The triplet regimen was especially effective in bortezomib non-refractory patients who were pretreated with 1 to 3 prior lines of therapy. In this subgroup, the overall response rate was 97%. The stringent complete response in this group was 10%, the CR rate was 23%, and the very good partial response was 41%. Across the full study, the ORR was 67%, which includes refractory patients. In chronic lymphocytic leukemia and small lymphocytic leukemia, treatment with the BTK inhibitor BGB-3111 demonstrated an objective response rate of 96%. The ORR with BGB-3111 consisted entirely of partial responses and PRs with lymphocytosis, which was 28%. Additionally, there were no complete responses at the time of the analysis. In those with high-risk molecular characteristics, such as 17p deletion or 11q deletion, the ORR was 100%. And last but not least, findings from the longest follow-up to date evaluating up to 5 years of ibrutinib in patients with chronic lymphocytic leukemia, small lymphocytic lymphoma, show that the agent is safe and effective. Results showed that 89% of both treatment-naive and relapsed patients experienced a complete or partial response to the therapy. This included a complete response rate of 14% for all treated patients. In the treatment-naive group, the ORR was 84% and was 86% among relapsed refractory patients. That's all for today. Thanks for watching OncLive News Network. I'm Justin Gallagher.